Well, good afternoon, and thank you for coming to our briefing. It's called After the PPACA, What Should Congress Do? My name is Twyla Braze. I'm president of the Citizens Council for Health Freedom. We're based in Minnesota, but we do work at a national level as well. So you will see papers coming out from us on things like our most recent one, which is on the National Patient Identifier. And you will see other things like on the health insurance exchanges that all have to do with a national basis. And when we're in Minnesota and the legislative session is in, we are working there as well, lobbying the Minnesota legislature. We are a national patient-centered health freedom organization, a nonprofit organization. We don't take any government grants. Our mission is to support patient and doctor freedom, medical innovation, and the right of citizens to a confidential patient-doctor relationship. And in the process of this presentation today, I hope that you will come to understand why we think that privacy and confidentiality is so important to the patient-doctor relationship and to freedom in healthcare in this country. With me today is Dr. Marcy Cook, and she is head of the Virginia chapter of Docs for Patient Care, and she'll give more of an explanation to you when she gets up and speaks after I do. I will be answering 3 questions related to patient-centered care and protecting and preserving health freedom in this country through policy, whereas Dr. Cook will describe to you what it's like for doctors and patients today, whether or not the federal health care reform law goes away or whether it stays in place. And she will talk about what can be done to protect the excellence of healthcare in America today for patients. So we've titled this presentation After the PPACA. And I realize that none of us have any idea what's going to happen on Thursday. But because our organization has some serious concerns with some of the post-ACA proposals, both by Congress and by the states, we're going to talk from that perspective to share those policy concerns with you. So I'm going to pose 2 questions and share the answers and the rationale with you, and then I'll discuss where we want healthcare to go for the protection of patients and the preservation of freedom. So question number 1. Should the ACA's so-called popular provisions be retained or restored in federal law? We call these the ABC provisions. A, allowing adult children to remain on their parents' policies to age 26. B, banning pre-existing condition exclusions. And C, closing the Medicare donut hole. We do not support retaining or restoring any of these, and I'd like to explain why. First, the adult children and the pre-existing condition provisions are government interference in business operations of private corporations and does not bode well for free enterprise. Second, the adult children provision has already increased the cost of family insurance policies. It's eliminated inexpensive child-only policies in at least 17 states. It has led to greater dependency of children or young adults and crowd out as these young adults drop other insurance and go onto their parents' policies. And then according to the Commonwealth study, a recent Commonwealth study, the benefits have accrued disproportionately to the wealthy and the influential. Our third reason is the ban on pre-existing condition exclusions, otherwise known as guaranteed issue, would be the end of health insurance and the beginning of universal health care or national health care using private, highly regulated health plans. An insurance policy, as you may know, is purchased prior to an insurable event in order to protect against financial disaster if that insurable event actually takes place. But forcing insurers to offer coverage to those who have already had an insurable event, to those already sick or injured, is not insurance. It is government-mandated third-party financing. In other words, it's universal coverage. So what homeowner insurance company would be willing to sell insurance to someone whose house is going up in flames? Under guaranteed issue, health plans would be forced to sell to the sick. Furthermore, because people could wait to buy insurance until they were sick, insurance policies would become unaffordable and even those with a guaranteed right to buy them may not find them affordable. And fourth, closing the donut hole will add to the cost of the program for taxpayers and eliminate the cost controls established by Congress. So here's the second question. Should Congress fund the establishment and operation of government health insurance exchanges? Our answer is no, and we have helped several states to say no to their proposed exchanges. If the law is overturned, states should be required to refund all the unspent dollars, and Congress should do everything possible to stop the imposition of these exchanges in the states. We view the health insurance exchanges, government-established website portals, as the key infrastructure being used to impose a national healthcare system. We call them federal takeover centers. And if you would look at just what the requirements are for these centers, you would realize how very involved the federal government is. The federal government is establishing a federal data services hub, and I have seen the document talking about what it's going to do. That hub is a process by which the federal government will exert its federal control into the states. We listened with concern as HHS in a press conference told states to prepare for being part of a federally facilitated exchange with the federal government in charge of everything except in-state customer relations and health plan management. As opposed to how exchanges have been discussed, we believe that there are no state exchanges. There is one national exchange with 50 state-based website portals. So one exchange, 50 portals. And if you go onto our website, we actually have a diagram of that, and I apologize for not bringing it. It was one thing that slipped my mind to bring. So all of those portals are under the same federal law as the, quote, federal exchange, and they're all under the same growing list of federal rules. So we look at it as no state exchanges and one federal or one national exchange with 50 state portals. There are at least 3 reasons why we remain concerned, even if the entire law is struck down on Thursday, regarding the health insurance exchange. First, HHS has given $1 billion for the establishment and IT infrastructure of the state-based website portals. When an Illinois reporter asked at a press conference, telephone call, asked HHS twice if they would have to give the money back if the law was overturned, Steve Larson, who is head of the CCIIO, which I hear is CCIO, or at least that's what I've been told is how it's pronounced out here, Steve Larson declined to answer, even though the reporter came back and said, you know, let me know, because Illinois was getting this money. We believe that the administration intends that these dollars be used to continue building the infrastructure for federal control and national health care into the future, even if the law is gone. Our second reason for concern is that various states appear ready to implement the federally controlled website portals, even if the federal law is overturned. We would like states to just say no. By saying no, they would make it clear to the public that this is a federal structure, not a state structure. They would also make it clear that they make it more clear about how the tax subsidies are related to the exchange and how expensive health insurance policies are as a result of the only place that a tax subsidy can be given is through a state-established exchange, not a federally established exchange. So by saying no, state legislators would essentially protect their people from greater dependency on the federal government into the middle class. And third, we are concerned because both the government and industry seem to be already planning to continue implementation regardless of what happens with the ruling on Thursday. So in September, it was just announced that there will be a major conference called the 2012 Health Insurance Exchanges and ACA 2.0 Summit. And that is to discuss what will happen with the exchanges post-ruling. And it has presentations from major players across the country, including from Levitt Partners. Thus, you may be wondering if our organization, CCHF, does not want to continue down the current healthcare reform road, where do we want to go? Our focus is on the 4 C's of care and coverage. These 4 C's will lead to less expensive, less intrusive, more compassionate, individualized, customized, patient-centered care, the backbone of excellence of healthcare in this country. So what are these 4 C's? The first C is cash. We support cash payments for routine, minor, and preventive care. This will reduce costs, eliminate most expensive paperwork, strengthen the patient-doctor relationship, and encourage visible and competitive pricing. It will also allow most doctors to leave the large group practices that they have been forced into, and they'll be able to specialize in patient care as they are able to and willing to do. The second C is catastrophic coverage. This is true health insurance, as opposed to prepaid health care, which is what the managed care organizations are. The catastrophic coverage is a deductible, has a deductible as high as $10,000, which today isn't even allowed for the health savings accounts, as probably most of you know. It should also be a defined contribution policy, and it should be paid to the patient, not to the hospital or to the doctor, so that there is a 2-way relationship here rather than a 3-way circle under which most of the controls over physicians are being imposed today. It would also provide non-health plan options, in other words, non-managed care options for insurance. And you may not know, but you're so well learned, you probably do, but just in case, that the federal health care reform law says that there is no catastrophic coverage for anyone after the age of 29. So there are a lot of people who have private health insurance policies with catastrophic coverage who are losing them because it's no longer lawful as of 2014. And a lot of the insurance companies are already dropping those policies and their people with it. The third C is charity. Charity, as opposed to what some people might say about it, we do not consider charity a dirty word. We consider charity part of the backbone, part of the principles of the healthcare system, part of what the whole system was based on. Charity, taking care of patients who are in need of care. So charity is also less expensive than is Medicaid. Charity involves no paperwork. Charity involves giving care, not coverage, but care when you need it. And that, after all, is what coverage is about. People don't buy coverage for coverage. They buy coverage to ensure themselves that there will be care, because that's what every patient wants, is care. The other thing that will happen is that there will be gratitude from the recipients, which I'm a nurse, and I can tell you, having worked with the entitlement programs, that there is often not gratitude. There's instead this whole entitlement attitude. And we would like it if the folks who were receiving services for free actually understood that it's coming from somewhere. That's not them, and to be grateful for it. Charity also speaks to the mission of medicine, to care for those in need. We believe that charitable institutions, including hospitals, should be encouraged to reemerge across the country as places of charitable, patient-centered care. Now to the last C, the fourth C, which is confidentiality. Confidentiality is key to patient trust and timely, accurate medical care. But today, 2.2 million entities have access to the patient's medical record without the patient's consent. This is as a result of the so-called HIPAA privacy rule and because of the HITECH Act. This number is from a federal regulation. 600,000 entities have access through HIPAA, and 1.5 million have access through HITECH, meaning essentially, of course, that there is no privacy, despite what most of the public thinks about HIPAA. In addition, the proposed Nationwide Health Information Network, or NHIN, and the required unique patient identifier in the HIPAA law, and the $27 billion in HITECH, as well as the HITECH mandate that every doctor have an interoperable electronic medical record to be put onto the NHIN, all of that will exacerbate the lack of patient privacy. Everything will be online and available to the 2.2 million entities. We view confidentiality as less about privacy than about individual control over what happens at the doctor's office and about medical decisions. So he who holds the data makes the rules. And that's the way it has been for a long time. If you've got the data and somebody else doesn't have the data, you have more power. Right now, there are a lot of folks, a lot of entities, a lot of organizations getting data on patients that even patients don't know about themselves. Even patients aren't aware of the data that's in their record. Also, this data is being used to create one-size-fits-all treatment protocols, which are placed on the doctor's computer screen, where the use of them is tracked and measured. As one doctor recently told me, if it's not on the computer, I can't do it. So this, of course, means that doctors are not always acting in the patient's best interest. They're not able even to provide individualized patient care. They become more like technicians following the orders of outsiders. This is a violation of professional ethics and of the patient-doctor relationship. So to end these violations, we suggest that we suggest consent requirements for the NHIN, consent requirements for the sharing of data, consent requirements to have your information shared anywhere outside the clinic or the healthcare system that you're a part of, consent requirements for the government to access it. We would also suggest a repeal of the administrative simplification section that allows all of this to take place, that allows all our data to be made available, that requires the unique patient identifier, the national patient ID for the tracking and linking of healthcare. We would also like a rescission of the HIPAA privacy rule and a repeal of the HITECH Act. In our handout, we also include some suggested actions to protect everyone's access to individualized care, to build a system of private health insurance that does not disappear at age 65, to move toward individually owned health insurance, preferably pre-birth, to limit the possibilities of pre-existing condition exclusions, and to protect our nation from the fiscal disaster of Medicare's unfunded liability, which is approximately 3 times our national debt. These suggestions include repealing the prohibition on senior citizens paying cash for care. They can't pay cash for care today without it being considered fraud to the one who accepts the money. We also would like HHS to be prohibited from withholding Social Security benefits from anyone who chooses to disenroll from Medicare Part A. There's already a lawsuit on this, which is heading to the Federal Appeals Court. We would also like to encourage disenrollment from Medicare for all seniors who have the means to care for themselves. Our vision for health care includes private, real health insurance. It includes medical charity. It includes tax equity, competitive prices, independent doctors, and patient-centered care. So to conclude, our organization supports patient and doctor freedom, including freedom from government-mandated insurance and from government health data tracking and linking systems. We have a healthcare system only because we have patients and who are people in need of medical care. And if the system doesn't work for patients, it doesn't work. That's the only reason we have a healthcare system. So patients should be the central focus of the healthcare system, taking care of the patient's needs. Today, the mission of medicine is being taken over by the business of healthcare. Entire industries have been created which are completely unnecessary for patient care and often interfere with it. Regulations and encroachments into the practice of medicine threaten the integrity of patient care. The United States is rated #1 in patient-centeredness by the World Health Organization. I would ask you to ignore the number 37 that you may have heard that we're rated number 37th in the world. After having read the WHO's report, what you have to understand is that we don't ration care, and they didn't like that. We don't centralize dollars or medical decisions, and they didn't like that. And we had health savings accounts, which they specifically said that they didn't like. So that's why they gave us a 37 rating. But they said very deep into the report that the United States is actually #1 in patient-centeredness. But that never really made the news. So we must not allow government and corporate interests to destroy our excellence in medical care. We must not give doctors a reason to retire. I don't know if you've seen the recent survey by the Doctor Patient Medical Association, which says that 89% of the doctors are considering quitting. So that's not what we need at a time when all the baby boomers are coming and are in need of more doctors, not less of them. So instead, we must focus on the 4 C's, and we would like your members to focus on making the 4 C's happen and to move our healthcare system back into the mission of medicine. Thank you very much. So now what I'm going to have Marcy do here is Dr. Cook can come up here and give you a presentation, and then after that we will have Q&A with both of us.
Thank you, everybody, for coming, and thank you, Twyla, for inviting me to participate today. I am a physician. I'm in private solo practice, boots on the ground, taking care of my patients. I'm also president of the Virginia chapter of Docs for Patient Care. This is a physician organization whose mission is to protect the doctor-patient relationship, and we'll talk more about what that means down the road. I want to share with you my perspective as a physician about healthcare today and where we're going in our healthcare. In the realm of healthcare reform, we hear a lot about cost, access, and quality. All three are important, but affordable cost and easy access don't mean anything if we don't have good quality. So I want to focus on quality for a little bit. Quality in this healthcare reform debate has been redefined, and it now emphasizes two factors. One is efficiency, which really means your use of resources, which really is a cost measurement. The second factor is meaningful use of the electronic health record. This is really a measure of practice function. Let's look at true quality. This is the issue of what you really want as a patient from your doctor. So I'd like you to take your business hat off for just a second and put on your personal hats. And I want you to pretend that you've had this nagging headache all week, but you've been too busy to do anything about it. But this morning you woke up and your headache was so severe that you couldn't even see straight. You're in pain and you're scared. What do you want from your doctor? You want to choose your doctor, who you want to go to. You hope that your doctor will listen to you, your unique story. Perhaps you've had migraines your whole life, or perhaps you have a brother who died of a brain tumor. You want your doctor to apply his education and his experience and use medical standards, medical sound principles to come up with the best plan for diagnosis and treatment. And you want to know all the choices available to you. And then you want to know that all of these resources are also available to you. And you want confidentiality. This interaction defines the doctor-patient relationship. This represents true quality. Its components are choice of your doctor, individualized care, medical-based standards, decisions made by the doctor and the patient, a full range of options available to you, and privacy. I'd like to step back with you and look at the relationship between cost and quality. And I want you to think about all the goods and services you've ever purchased. There's always a relationship between cost and quality, and it's usually directly related. I'd like to submit to you that in our efforts in this healthcare debate to control cost, we've impacted true quality way too much. We are, in a sense, killing the goose that laid the golden egg. I'd like to discuss with you 4 methods that have been used to control cost that have ultimately led to decreased quality of care. We're all focused on the Affordable Care Act, but I would like to submit that the Affordable Care Act is really an extension of methods that have already been in motion. And so regardless of the outcome of the Affordable Care Act, we must address these methods and how they're impacting quality. I'm going to present 4 building blocks, and if you stick with me, I'll put it all together at the end. The first building block is standards of care. Standards of care are guidelines that inform the physician how to diagnose diseases and how to treat diseases. They were originally set by medical societies based on medical principles. But in an effort to control the use of resources, i.e. cost, insurance companies started publishing their protocols for dealing with disease. And then federal agencies, such as the U.S. Preventative Task Force, started publishing their protocols. And then in the Accountable Care Act, we have the Patient-Centered Outcomes Research Institute, which is an entity that determines the best treatment using formulas that include the cost of treatment based on the years of benefit. This is a formula that determines whether your life is worth treating at your age. So here what we see is a shift from medical principles to cost principles in determining the standards of care. And I'd like to ask you a few questions. Who is setting these standards? Is it a medical institution or bureaucrats? What is the basis for these standards? Is it medical care or cost containment? And what if your unique situation doesn't fit neatly into one of these standard protocols? For example, the U.S. Preventative Services Task Force recently put out guidelines for mammograms. These were in direct conflict with standards that were put out by the American Cancer Society, the American Radiology Society, and the American College of OBGYN. Your doctor, however, is now compelled to follow these new standards, even when they conflict with the traditional standards. Why and how, I will explain in a minute. The second building block is delivery models. Medicine was based on the private practice model, whose hallmark was choice and the doctor-patient relationship. Again, in an effort to control resource use, i.e. cost, insurance companies developed the HMO concept. This is where the doctor served as a gatekeeper to try and control and manage the resources that patients used. The Affordable Care Act went even further and developed the Accountable Care Organization. Now the gatekeeper is a businessman, usually, who's managing the doctor's use of resources. So here we see a shift from choice and personal relationship to a closed system that restricts the patient's use of doctors and resources. I have another question for you. Patients hated the restrictions of choice in an HMO. Why will they like any better the accountable care organizations? The third building block is payment models. The original model in medicine was fee for service, honest pay for honest work. Every other business works this way. Consumers are aware of the cost, and the consumer has the responsibility to pay. This drives the consumer to look for good value. By value, I mean the best quality at the best price. This is what keeps businesses open, and this is what shuts business down. The consumer has that control. Two things change this. Employers offered insurance as benefits, so patients no longer had skin in the game. And insurance companies, in an effort to reduce costs, replaced their indemnity policies with managed care. This created a disconnect between the actual cost and the service. Service was now bundled into units of care. There were global fees, capitated fees, and episodes of care. The reasoning went like this. If we don't pay the doctor for the actual services rendered, and instead pay a set fee for a unit of time spent, as in global fees, or a set fee per patient, as in capitated fees, or a set fee per diagnosis, as an episode of care fees, this will force the doctor to use fewer resources. The Affordable Care Act took this even a step further, using the power of payment to control your doctor's behavior by championing pay-for-performance models. With this model, the doctor's pay is modified based on his adherence to certain standards. This is what compels the doctor to adhere to standards of care that are set by entities other than the medical societies. His education and experience are irrelevant because if he doesn't follow these protocols, he won't be paid adequately, he won't be able to keep his business running, and he won't be able to see patients. Whoever pays holds the power. Who do you want your physician working for? You, the patient, or a businessman counting his use of resources? So here we see a shift from honest pay for honest work that allows the patient consumer to seek good value to a disconnect between the fee and the service. The patient is no longer aware of the fee, and the doctor's service is measured now by adherence to protocols. The last building block is the electronic health record. Does anyone know how we know what happens in the privacy of a doctor's office? That interaction between the patient and the doctor? This data is captured in several ways. Medical data is captured through insurance claims. Medical data is captured through soon-to-be mandatory reporting requirements. And now we have a new way with the electronic health record. The electronic health record began as a way to organize medical information. In our effort to control cost, the focus became as a way to reduce the duplication of services. Now, with the advent of the Affordable Care Act, we can easily see it being used as a tool to access data about your physician's use of resources. To see how much we've affected quality in our attempts to control cost, I want you to think about the very entities that brought medical privacy to the forefront with HIPAA now have your personal medical information flowing on the electronic health record superhighway to multiple data centers. And you can only hope that there won't be a glitch like what happened to a clinic in the Midwest where all of their clinic records went up on the internet and nobody knew. So let's put all these building blocks together. Let's come back to your morning with a severe headache. Remember how you imagined your interaction with the doctor to be. Now I want you to imagine this new model of care. Your friend recommended a great doctor for you to see, but you can't see him because he's not in your accountable care organization. Once you get to this doctor who you've only just met for the first time, he'll ask you a bunch of questions, and he'll feed your answers into an electronic health record. And the electronic health record will spit out a protocol for the doctor to follow. There won't be any need for conversation because there won't be any choices. And if you want your doctor to do a particular test that isn't on this protocol, he won't, because every move he makes will be captured by the electronic health record. And if he wavers from this protocol, he'll be paid less, and his quality rating will be downgraded on a public website. So in the effort to reduce cost, this has led us to this new model of care, whose hallmarks are restricted availability of doctors and resources, standardized protocols, cost-based standards, centralized bureaucratic control of decisions, restricted options, and loss of privacy. This is our new quality health care. So let's talk about cost, because cost is very important, but we can't sacrifice quality. So as you're contemplating ways to change the healthcare system via standards of care, delivery models, payment models, and what the electronic health record can do for you, I want you to consider a very simple way to lower cost while preserving quality. I want you to think about reestablishing the patient as consumer. This requires reconnecting the fee with the service. Let the consumer purchase his own policy. He won't be tied to his employer, and he has a vested interest in his care. Restore insurance to how it was meant to be, to cover catastrophes. Don't fill insurance policies with mandates for routine care and mandates for care that you will never use. And lastly, make the consumer, patient, and the doctor aware of the actual prices for all the services and medical goods. With the patient as consumer, he will demand value, and the essence of value is the lowest cost for the best quality. Thank you.
Thank you very much. Well, now is the time for Q&A, and we have about 20 minutes available for that. So Marcy, actually, you can come up here because this is where the microphones are.
Oh, okay.
So, does anyone have any questions? Anything that they'd like to ask? Yes.
Do you think we're already so far into the electronic data, the whole HIM system and all of the electronic record keeping and all the, the grants and everything that's been sent and all the mandates on the doctor that we can reverse it or stop it? Or, I mean, obviously legislation could help that, but what do you propose?
Well, I'll speak first. One thing that I think about electronic medical records is electronic medical records are fine, they're okay, and they need to meet the needs of the doctor and the patient. And a lot of the people that I talk to who are physicians and who are nurses have no nice things to say about electronic medical records. They talk about the disconnect between the sections, trying to find the part of the data that they want, not being able to find it, doing extra tests as a result of not being able to find it. They talk about copying extra things in that they're just pasting and copying so the electronic medical record looks really good, but it's also very difficult to find anything in. And so when I think about electronic health records, I have no problem at all with the doctor's office deciding that they want to do it for themselves. What I have a problem with is the interoperability, that they have to be interoperable, that they have to be on the National Health Information Network, and that there's no consent whatsoever for that data getting outside of that doctor's office. So in my opinion, there will be lots of doctors that will choose, if they had a choice, they would choose no electronic health record because they don't need it in their office. There are lots of hospitals that have not transitioned over. The really big organizations have, but not lots of the small ones. And lots of smaller clinics and practices, they haven't transferred either. I don't believe we are so far that we can't stop. And I do believe that even though everyone got electronic health records, if the interoperability aspect was only under the consent of the patient, that would preserve the privacy. So there's nothing wrong with electronic health records all by themselves. What's wrong is that they are required to be interoperable and that their data goes everywhere, hither and yon, with the NHIN software, and that the patients have absolutely no control over it. And right now, there's a lot of doctors that are very unhappy with it. One doctor who wrote a very long article, which I wish I could remember his name, he talked about becoming a data drone, being just there to enter all the information and how much time that took away from his time with patients. So I think that there are problems. Do you have anything else to add?
Yeah, I think the concept of electronic health records is great because there is so much medical information, and we now no longer live in a system where you have one doctor, one community who knows everything about you. You have multiple doctors taking care of you, and wouldn't it be great if Dr. A knows what Dr. B was doing with you? But electronic health records are just not ready for prime time yet. There isn't the security, there isn't the interoperability, there isn't the practicality of these records. So while the concept is good, they're not ready for prime time. The other issue is don't underestimate your power as a consumer to change things. As I talked about, HMOs were the next best thing to everything in medicine. They were going to solve all the issues. Patients hated HMOs. So where are the HMOs today? The HMOs that still stand have lost the very concept of the HMO, which is restricting patients all under one roof, because patients don't like it. So don't underestimate your power as a consumer patient to change the road that we're going down.
Next question. Yes.
Yeah, of course, containing costs through competition is really the only solution to all of this, but our difficulty lies in dealing with feelings. How do you plan on managing the emergency room care laws? How do you transition that into charity?
Right. Well, you know what I think is really interesting is that the hospitals today are giving a lot of charity care. already today. You know, when I listen even at the Minnesota legislature and they talk about the disproportionate share, how much charity care that they're giving out, how much bad debt there is that they're getting. I foresee, as I mentioned, actually a new type of hospital, sort of like going back to the future, where there are actual charity hospitals run by organizations, just like there used to be. So I see both. I see charity from the private entities, and I see charity in real charity hospitals.
So is this a cold turkey thing? Pass a law and boom? And the other question.
Well, I have to just say that, I have to say that what I would like is a medical charity deduction that will really encourage the charity enterprise to emerge. Because I feel like there are a lot of people who would be willing to give, but at this moment, so much of their money is being taken in taxes for the Medicaid over here, and Medicaid is for coverage. There's so much money that's going for coverage that's not actually being used for care, that would be available to be used for, well, not be taken from taxpayers and then given out in charity.
Then one follow-up and I'm done. Are you also consistent in your advocacy for competition amongst doctors? In other words, not having organizations that limit the flow and supply of doctors. That seems to be an issue to me. Do you advocate for more liberal licensing practices?
You know, doctors.
Especially for
So I'm talking right here next to a doctor, and I'm a nurse. But you know, I have some fairly strong opinions about doctors, because I have a great concern. One of the things that I will ask people is, do you want a doctor in your future? Because the doctor you want is a critically thinking doctor. The doctor you want is a smart doctor who looks at you as an individual, because your situation is not your neighbor's situation, and you want them to think, now what is it particularly about Jim here that I need to think about? But the fact of all this standardization happening over here, the smart person who was thinking about being a doctor is going to say, you know what? I can have 4 years of education, work 9 to 5, make a better income, not have to worry about being imprisoned, not have to deal with the government. You know what? I'm not going to become a doctor. And I think we want good doctors, and we want smart people being doctors. And I hear so many doctors who say, I don't want my children to be doctors, I want to quit early. There was an entire radiology practice in Minnesota that half of them were going to leave the practice. They all had different ideas, and then the market crashed, so they had to stay as radiologists. But their whole plan is to leave. So when you talk about liberalizing the policies, perhaps mostly what I think about is how can we keep doctors, and how can we get students who are really smart and compassionate and critically thinking to actually consider the field. Does that answer your question, or
Not
am I
really.
kidding?
Those will be chosen by people. The good ones will be chosen. The fact is supply. At one time we had a dentist issue. And then we built.
Do you mean opening the medical schools?
We opened it up and had a bunch more dental schools,
Right.
and our dental prices went down. LASIKs,
Yes.
not paid for by insurance.
Right.
Prices went down. Anybody could enter into that practice.
Right.
So supply
Okay.
on the provider side is important as well. So I
Yes.
just wondered if your organization was pushing that in any way, and it sounds like no.
We're not specifically pushing that. Most of it we're pushing our organization now. Her organization might be different, she can speak to that, but our organization is particularly pushing against the things that would keep doctors from choosing to actually be part of the profession, or choosing to, stay or leave.
Thanks.
And that's the key, keeping being a physician a profession, because we've seen over the years that our ability to control how we're reimbursed for the services we provide is totally taken out of our control. But what really has pushed physicians is that when we can no longer use our education and our experience to make decisions for ourselves, we're no longer professionals, we're technicians. And to ask somebody to go through years and years of training why would you do that when you can't utilize that training if you're just following standard protocols? So it's a question of keeping the profession in medicine, and that will attract people to the profession.
I have to encourage you to go to the Doctor Patient Medical Association survey. It is right on their homepage, and you can see the quotes from the doctors who took the survey, including one that said something like, I've been thinking about going to Africa or India or somewhere where I can just take care of patients, right? So this is, just consider going there because it's a very interesting survey. Is there another question? Yes.
You've talked a lot about your concern with the electronic medical records. What would you say about a system in which the security was designed so that a doctor or any kind of care professional would have to declare their relationship with the patient, and then that relationship would have to match a registration, and the patient can go online and track and see every single healthcare professional that had logged onto the system and then looked at their information? What would you say about a system that would be designed in that way?
That brings up several things. One is that we have tried to get auditing audit trails for patients to see in Minnesota law. We've tried that very unsuccessfully because those who have the records do not want any kind of audit trail. And we do believe in an audit trail. I would say, though, that we wouldn't be supportive of a government system, a national health information network, even if it had that, because if it's a private system, you can come and go and you can make choices about whether you want to participate or not. But if everybody is required to be on the National Health Information Network and the doctors are required to put your medical records on there, then all sorts of other folks are likely to have access. If they said that it was total consent, there would be no option but consent, I would still worry just because of the fact that it's a national system. That makes it open up to the Congress to change their mind. Any private entity can start up with electronic medical records, and any patient can decide, this is what I want to do. I'll put my medical record there. There will be passcodes for all my doctors. This is great for me. That's fine. Then that would be a private system. Okay.
Plus, once you have a system like we have where there is not a private relationship between the patient and the doctor in terms of the payment arrangement, you have all these third parties in the middle of the payment arrangement. All of those third parties need access to those records because they're making decisions about payment based on medical necessity. So you've opened up that data to so many entities.
So I think, to just tag on to that, I think perhaps in order to get what you're saying, and I'm sorry I don't know your name, but in order to get what you're saying there would require a different relationship between the patient and the doctor that didn't have all those third parties in there.
Okay, thank you.
Right.
Yes.
I've worked with Dr. Keith Smith of Oklahoma before, and he runs a surgery center where he posts his prices online, and his prices seem to run right around 10% of what a hospital charges. And you were talking about cash-based payments earlier. What do you see if cash was being paid, what the prices would be for the medical profession?
Well,
Look at a prime example when LASIK first came out, and it was extraordinarily expensive, and then other ophthalmologists and physicians got into the LASIK market, and look where LASIK prices are now. That's competition at work.
and for those of you who have never heard of the Patmos Clinic, pay at the moment of service. They take no insurance, they take no Medicare, they take no Medicaid, but they have Medicaid recipients who come to the clinic and pay cash. Because one, they know they're going to be looked at not because they're not like a Medicaid patient, but just like a patient, and they know they can get timely access to care. The clinic had 3,000 patients when I first heard of it. When I next heard an article on it, it had 7,000 patients, and they were looking for a second doctor. So the idea of cash, it's so much less expensive. He's only got, I think, a nurse to help answer phone calls and do a little. It's just him and a nurse, and he was looking for another doctor. So it's much less expensive because they have the paperwork out of there and the controls out of there. Any more questions? Okay, then. We're all done. Thank you so much for coming. We'll stick around in case you have any questions or want any more information.